We're going to go ahead to finish our session on treatments of spinal fluid leaks. And our next speaker is a really good friend of mine, Dr. Ian Carroll. He is not at Stanford right now. Maybe he'll tell us where he actually is. But he's a professor of anesthesiology at Stanford. I think he did his training at Stanford. He went to medical school in Columbia. He's like quadruple board certified. And he has single-handedly really started the whole CSF Leak program at Stanford. It's an amazing job he's done. So Ian, please share your wisdom with us. And I think he's actually going to talk about doing blood patches on patients who don't have a leak.
Yes, my plan is to talk to you about the people who we've excluded from having a leak. I'm actually in Paris. My wife is having her 50th birthday, and her desire was to come to Paris, and so here we are. And it's the middle of the night here, and I've been up a long time, so you're going to see me refer to my notes from time to time. The only thing I regret is that we're not all together, because the socializing with people who know so much about leaks is one of the things that I enjoy most. But with that, let me go ahead and get started. Thank you for having me. For those who don't know me, I'm Ian Carroll. I'm going to be discussing the outcome of epidural blood patching in patients who fail to meet ICHD3 diagnostic criteria. Give me 1 second here. I have no disclosures. Our work is supported by the Considine CSF Leak Fund. This paper caught my attention a few years back by Hosoya and colleagues from Japan, not because of the floating dural sac sign, but because of their methodology. They prospectively gathered 100 patients with orthostatic headache suspected of having a CSF leak at a consortium of 11 hospitals in Japan. Upon evaluation of the 89 brain MRIs, only 20 were positive, and of the 70 axial T2 spine MRIs and 86 MR myelograms, only 16 were positive. So overall, 77 of 100 patients prospectively gathered with suspected CSF leak had none seen on imaging. And as far as I know, this is the only prospectively gathered cohort of orthostatic headache patients documenting all of these imaging techniques, and the only one to document that 4/5 of the patients with orthostatic symptoms don't have positive imaging and therefore will not meet the diagnostic criteria. So anyhow, this agrees with my experience, with the fundamental difference that while they felt they had ruled out a leak, I don't believe criteria B shown here is sensitive enough to be used in clinical practice to rule out a leak. And in 2016, with this patient, I began offering a trial of empiric blood patches to patients with orthostatic headache and negative imaging, a practice not new to the other treaters in this conference, but at the time, an unfamiliar experience for me. This colleague was uncomfortable with that practice and wrote a letter to my chair stating he was concerned that offering a patch to a patient like this might constitute malpractice. And given the diagnostic criteria, that's not crazy. And this turned out to actually be very helpful, because in response, rather than telling me to stop, the chair asked me as part of a quality assurance project to begin collecting data prospectively on the outcomes we were achieving. To this end, we used a web-based platform called Qualtrics to deploy a series of validated outcome measures listed here to measure core symptoms of CSF leak. So at that point, we began prospectively gathering these measurements on all patients who underwent treatment for a suspected CSF leak at Stanford. The questionnaire was given before the first patch, 1 month after the first patch, and monthly thereafter, with most patients continuing to have measures following additional patches. Delayed follow-up following the final patch was also captured, ranging from 2 months to 2 years later. The analysis and reporting of this data has been approved by the IRB at Stanford. Between August 2016 and November 2018, all patients undergoing epidural patching were asked to complete the measures. 139 individuals did so, of whom 124 completed at least one measure pre and post patch and are included in the patient cohort. Demographic characteristics are shown here. The cohort was disproportionately female. 20% would show elevations of CSF protein from fluid drawn at the time of their CT myelogram. And this is the breakdown of the imaging results and opening pressures from those patients with clinically suspected CSF leaks. Now recognize someone who had a second half of the day headache who might not have said, oh, my headaches are clearly postural, but had a second half of the day headache. We might have considered them, if they also had tinnitus and neck pain and a sense of oral fullness, to be a good clinical story for a CSF leak without them necessarily saying, I have a clearly orthostatic headache. But this is the breakdown of the imaging results and opening pressures. And the opening pressures had been collected while the patient was in the prone position, obtaining a CT myelogram. We could retrospectively ascertain ICHD3 criteria data for 120 patients, of whom 23 met criteria B by either opening pressure or imaging. If we assume that these are the true positives, and this data agrees pretty well with Hosoya's data that similarly found about 20% of people with a good story actually turned out to have positive imaging. So if we assume that these are the true positives, patients who had the right symptoms and who met ICHD3 criteria, then none of the individual studies to satisfy criteria B performed all that well. All of the studies identified fewer than half the patients who met ICHD3 criteria. Of those studies, MRI of the brain performed the best, only 9 of 23, or 41% sensitivity, while MRI of the spine performed the worst in these terms, identifying only 5 of the 23, which would be a 22% sensitivity, a far cry from the 90% sensitivity that's bandied about. CT myelogram, which I find invaluable in deciding where to patch because of things that people have talked about earlier today, such as finding tiny focal bone spurs, performed badly also in terms of sensitivity, identifying only 7 of 23 ICHD3 positive cases, or 30%. So I tell patients we use CT myelogram not to decide who to patch, but to decide where to patch. Using all conventional imaging and opening pressure, our yield among patients with a good clinical story for CSF leak was 19%, which is roughly in line with Hosoya's data as well. And we should put that in contemporary perspective with what's known now and was not known then. Mayo Clinic has reported that in their cohort of patients who underwent lateral decubitus digital subtraction myelogram for detection of CSF venous fistula, of 24 patients with orthostatic headache but normal conventional brain and spine MRI, 8 had a CSF venous fistula, or 33%. And Cedars has reported a 10% yield in such patients, or 20% if they have a perineural cyst. And my point here is that had these patients had the opportunity to have a lateral decubitus digital subtraction myelogram, which at the time we collected data for them had not yet been described, the yield from having a lateral decubitus digital subtraction myelogram that we would estimate we might have found would be pretty close to the 19% that we found with all of the conventional studies that make up the normal criteria B combined. And that has, I think, some significant implications for really what's the best test and how people with orthostatic symptoms should be evaluated, especially uncomfortable given how few centers actually can do this. This cohort was defined as the consecutive patients who underwent patches and provided data. So whether they met ICDH3 criteria or not, all of the patients were patched. Of these patients, the average number of patches was 5.5, and the patches were most commonly multi-level. The aggregate location of those patches is shown here throughout the spine and reflects that we targeted any level of the spine that looked different. If it had a little osteophyte, if it had a perineural cyst, if there was an asymmetrically opacified nerve root. It's a little different than the non-directed approach some other centers have used to try and treat these similar patients. And here's what we observed. The top half of the table are the results 1 month after the first patch, and the bottom part of the table are the results when we look at the last observation after the last patch, from 2 months to 2 years later, depending on the respondent. Here are the measurements before the first patch, and these are the measurements after patching, and the associated p-values for change. The first thing to notice is at baseline, the patients rate highly on all symptoms of CSF leak. The second thing to notice is how distressed they are. Mean physical health was at the 4th percentile, as reflected by the PROMIS Quality of Life Global Health metric. And HIT6 mean score was 65.7, suggesting severe impact of headache. And while not segregated here, we compared these metrics among those who did and did not meet ICHD3 criteria. No symptom measure differed significantly between those patients who did and those patients who did not meet ICHD3 criteria. From a symptom metric perspective, they appeared identical. 1 month following their first patch, statistically significant but modest improvements were seen in a number of metrics, including quality of life, physical subscale, headache, but also fatigue, neck pain, and dizziness, but not quality of life, mental health domain, not tinnitus, and not nausea. And what I want you to take away from this, before we go down to the bottom part of this, what I want you to take away from this is, first of all, the patients are not worse off for the aggressive treatment approach pursued. We can argue about whether the benefit seen is from placebo response or regression to the mean or Hawthorne effect or a true treatment effect, and that's important. But this treatment approach is associated with modest, statistically significant improvements across a broad range of measures, not harm. When followed remotely after their last patch, the patients have all continued to improve across all measures, and measures such as PROMIS Quality of Life Mental Health subscale, which were not statistically significantly improved after the first patch, are now significantly better when we have more remote follow-up after their last patch. This is true of nausea as well. All metrics improved and improved more with repeated patching, all except tinnitus, which seemed to not improve at all. Again, we can argue about whether the benefits come from placebo or treatment, but these patients became modestly healthier across a broad range of measures of both global health and specific symptoms, and this effect became more rather than less prominent in the face of additional patches and time. In addition, under the null hypothesis that treatment had no effect, these measurements provide a reasonable precision in estimating the upper bound for the magnitude of a possible placebo effect captured in each metric. For my colleagues at Duke and elsewhere planning clinical trials of epidural patching, your placebo effect cannot be larger in magnitude than the improvements documented here, and to the extent patches actually help, your placebo effect is by definition smaller than these improvements. And so you can use this as an upper bound limit for the degree of magnitude you might see in a placebo effect, and this can be helpful perhaps in powering your clinical trials. But we're not looking for statistical significance, we're looking for clinically meaningful improvement. Did treatments make a meaningful difference to the individual patients? Of the metrics we used, a minimal meaningful clinical difference, has been previously reported for 2 of the measures. For the HIT6, that's estimated to be a within individual change of 2.5. And for the PROMIS Quality of Life Physical Health subdomain, that number has been estimated to be as low as 1.7. We chose in our analysis that I'm about to show you a higher threshold than that at 2.5 as the minimum we would consider clinically meaningful. So that allows us to ask what percent of patients were responders, i.e. what percent of the patients had clinically meaningful improvement. Overall, when we look at the PROMIS Quality of Life Physical Health subscale, 78 of 119 patients, or 66% of patients, experienced a clinically meaningful improvement. When we look at the HIT6, 55% of patients experienced a clinically meaningful improvement. And this allows us to then ask, what predicted who would get better? To look at this, we did a nested case control analysis within the cohort. Cases were patients with clinically meaningful improvement. Controls were patients who did not respond meaningfully. And here's the data for the predictors of clinically meaningful improvements as assessed by the PROMIS Quality of Life Physical Health Subscale. And here are the variables we looked at as possible predictors. On the x-axis, we have the patients stratified into patients with clinically meaningful improvement or not. And the first thing you can see is that whether a patient met ICHD3 criteria was completely unrelated to whether they subsequently had a clinically meaningful improvement in physical quality of life. P was 0.32. And also, as you would expect, given the composite criteria B had no predictive value, the individual components did not have predictive value either. Neuroradiology read of MRI brain, spine, CT myelogram, and opening pressure all also failed to have any predictive value or predicting who would benefit from patching. In contrast, both a patient's unambiguous self-report that their headache was clearly postural and a moderate to high burn criteria probability score before patching were both significantly associated with an increased likelihood of being a responder. With regard to the burn criteria, this is driven primarily by the high rate of response among patients with burn criteria moderate probability score. So the burn criteria and patient report of orthostatic headache both had better predictive performance than the ICHD3 criteria. It's hard to explain these results under the null hypothesis that the statistically significant improvement across the board in global health and specific symptoms was the result of non-specific processes, such as the placebo effect. And this is even more remarkable given that all of the data and imaging collected here was collected before Dobrocky's paper in JAMA Neurology in 2019, putting forth the burn criteria. Patients could not have been selected for patching based on the criteria because those criteria did not exist yet. And all of the data that was analyzed here was already collected. Only now we're able to go back and assign those scores in a manner blinded to the results and see these relationships. While previously shown to predict the likelihood of having a positive CT myelogram, and also to predict the likelihood of a positive lateral decubitus digital subtraction myelogram, to my knowledge, this is the first time that the burn criteria has been shown to predict the outcome of treatment. The other thing worth noting here is that among 77 patients with clinically meaningful improvement in physical health, 17 were ICHD3 positive, but 61 were ICHD3 criteria negative. In other words, for every one clinical responder that the current criteria would say to patch, there were 3.6 patients who could and actually did benefit from patching that the application of the current ICHD3 criteria would have denied the diagnosis and possible patching. The criteria are excluding more potential responders than they identify by a 3.6 to 1 ratio. And that's sobering when you think about what happened to me when I started trying to patch patients who didn't meet criteria. This is the analogous data looking at predictors of clinically meaningful response as assessed by change in the HIT6. Again, ICHD3 criteria fail to predict benefit, but so do our other predictors. So the HIT6 may actually be a little less sensitive to change with patching than the PROMIS physical health measure. And this has implications again for our colleagues at Duke and it seems at Mayo as well, planning prospective trials to evaluate the effectiveness of interventions. To be specific, a PROMIS metric of global health may actually be more sensitive to change as a primary endpoint than the HIT6. But even with the HIT6, for every responder that met ICHD3 criteria, there were more than 3 clinical responders who the current diagnostic criteria would have excluded from patching. Before closing, I want to show you a few more details regarding the burn criteria scores. The first thing to note is that among the patients selected for a clinically compelling story, and before the publication of the burn criteria, when we went back and we applied the burn criteria post hoc and blinded to outcome, 50 of the 106 patients had probability scores that were moderate or high, even though, as I showed you earlier, only 9 had brain MRIs that were read as suspicious. And only 1 of 40 patients with moderate probability burn scores were noted to have any suspicious findings on the brain MRI as read by neuroradiology. In conclusion, at least 80% of patients with spinal CSF leak symptoms will not meet existing diagnostic criteria. The strategy of permissive epidural patching of such patients is not associated with reduced quality of life or harm or deterioration of any symptom. The use of a broad range of validated measures can detect and document modest improvements that are not as easily recognized or captured as the gratifying home run. On average, epidural patching of such patients in qualified hands is associated with modest improvements in quality of life and almost all other symptoms. These improvements appear to progress over time and with further patching rather than regressing. And the ICHD3 criteria failed to predict who would have clinically meaningful improvement in symptoms. In contrast, the simple question, are your headaches postural, and the brain findings comprising the burn criteria probability score had predictive associations with the likelihood of having a clinically meaningful improvement in physical dimensions of quality of life. And these 2 findings strongly suggest an explanation for the data other than the placebo effect. With regard to the burn criteria, it should be further noted that in this data set, the burn criteria have a better ability for predicting therapeutic outcome than ICHD3 criteria and also expert radiologist read of films that occurred before the publication of the burn criteria. Radiologists now may be familiar with those and perform better, we don't know. Further, the burn criteria have previously been reported to be associated with the likelihood of subsequent positive spinal diagnostic studies, including CT myelogram and lateral decubitus digital subtraction myelogram. And in this data, we show for the first time a predictive association with treatment outcome. These data have implications for clinical trial design that we've discussed. During that cohort, I had no serious adverse events. I have subsequently had 1 serious adverse event following the same strategy in a young woman who had patches and developed a severe DVT and subsequently PE requiring hospitalization after being counseled to stay flat for 72 hours after a blood patch delivered in this paradigm. She did turns out to be on oral contraceptives, which I hadn't asked about, and as a risk factor for DVT, and she turned out to also be a factor V Leiden heterozygote, which is not all that uncommon. And so those are things we should seek out if we're counseling people that spend prolonged time being flat to manage risk. And that is all I have to say about that. Thank you very much.